and I'm with the Department of Psychology, and I'm presenting my research, Mortars of Sanity, the evolving treatment of PTSD and veterans of the War on Terror. Here are some important terms you need to know. PTSD is trauma-induced distress, which leads to intrusive and avoidant symptoms, and is lasting for over 1 month. And the War on Terror was a global anti-terrorism campaign lasting from 2001 to 2021. The Iraq War lasted from 2003 to 2011, and the war in Afghanistan lasted from 2001 to 2021. Veterans Affairs, or the VA, is the US-based veteran healthcare system. Pharmacotherapy is medication-based mental health treatment, and psychotherapy is talk-based mental health treatment. So the question I'm trying to ask is, how have VA PTSD treatment guidelines changed from 2004 to 2023? How have data and statistics and treatment effectiveness changed over time? And how have the statistics changed, and how can treatment impact certain demographics? I looked at VA PTSD guidelines from 2004, 2010, 2017, and 2023, and I looked at PTSD prevalence within certain VA veteran demographics, as well as treatment utilization and outcomes, and I looked at trends and limitations and areas for improvement across different documents. So here's the broad evolution of the guidelines. What you need to know is that SSRIs were continuously recommended throughout the years, and they were used as the first-line medication. Starting in 2010, they started a stepped care approach to treatment where they would implement a certain treatment such as SSRIs, and if that didn't work, then they would implement another type of treatment or medication. So benzodiazepines were also not recommended for treating core PTSD symptoms, and they also started recommending importance for sleep hygiene in 2010, and they began incorporating telehealth in 2017, as well as trauma-focused psychotherapy, which began to be more higher recommended than pharmacotherapy, starting in 2023, which is where we're at currently. Moving on to the pharmacotherapy trends, we have SSRIs, like I mentioned, and the reason why SSRIs are continuously recommended is because they can also treat comorbid symptoms such as depression, and they can treat the core symptoms of PTSD really effectively. But starting in 2023, they were less implemented, even though they are still the main first-line treatment for medication. And they were looking at different types of medications, but mainly sertraline, fluoxetine, paroxetine are the main SSRIs prescribed. And so currently there are less medications being prescribed, but they are still the main treatment. Moving on to psychotherapy, we have cognitive behavioral therapy is the main treatment. We have cognitive therapy, exposure therapy, a lot of situational awareness and stress management techniques are being recommended over time. And we have EMDR, which is desensitization reprocessing, and prolonged exposure therapy, which are reprocessing or restructuring your own cognitive experiences, which is really helpful after experiencing a traumatic event. And when they began focusing on trauma-focused psychotherapy, there was a big treatment reluctance in veterans to undergo it. So now there's a big problem with treatment retention. So that is where future guidelines can look at. Next, I looked at veteran demographics. And I looked at a study which studied about 100,000 Iraq and Afghanistan veterans, and 13% were women and more than half were younger than 30. So it was found that younger veterans and those with certain demographics, such as women, ethnic minority groups, had a higher risk for developing PTSD. So this suggests that there is a need for age and gender sensitive approaches to PTSD treatment within the VA system, and also considering that a significant amount of veterans also have other mental health diagnoses. So my key findings are that the VA has a pretty good structured evidence-based PTSD care, but there are pretty strong challenges with treatment retention and maintaining trauma-focused psychotherapy in veterans, as well as understanding the long-term effects of SSRI prescriptions. And the future directions and implications are that we should implement more personalized care for specific demographics, such as women and older veterans, as well as those in certain minority groups, predicting treatment responses to SSRIs and other medications, as well as improving treatment retention, like I mentioned, addressing barriers to care, especially access to the VA healthcare system, which is really difficult for a lot of veterans to achieve. Implementing telehealth would be really important in this aspect. Long-term outcomes of certain medications and treatments would be really beneficial, especially trauma-focused psychotherapy. How does that affect the veterans long-term? Since they just recently started implementing that, that would be really important to look at moving forward. And specific policy changes, improving the impact of the VA healthcare system. How can it be more encompassed across America? And how can veterans seek the healthcare that they need more effectively? Thank you. Resources, any questions? I'll take any. Yeah.
I'm curious if you found that the difference in the rate of PTSD amongst women and men, if there was a difference in like treatment and care and how men and women are kind of treated by the greater VA.
In the guidelines, there isn't a lot of separation between how the treatments are applied. It's more here are the guidelines, here is how the person can implement them. So they have a list of all the medications, a list of all the treatments, and it's sort of up to the provider to say how can we best apply this to the specific person. And so it is by a case-by-case basis, but looking at the demographics, a lot of women are disproportionately impacted by PTSD and depression and comorbid symptoms and disorders. So I don't know exactly how impacted they are within the VA system or how good of the treatment that they're getting, since it's pretty under-researched and under-reported, but that would be something to look into for further research for sure. Yeah.
I think earlier in the slides you mentioned something about sleep hygiene. So how do other factors other than like therapy and treatment with medications, how do other factors like sleep sort of affect the treatment of veterans?
That's really important, and I was really surprised to find that in the guidelines, because they had a big emphasis on like setting a good sleep routine for veterans, because they would have a lot of nightmares and a lot of post-traumatic problems with sleep. So improving sleep would also greatly help with your overall cognitive health, and because that's like pretty well known that like good sleep is good for everything. So they would have a specific medication, prazosin, which would help for nightmares specifically. So a lot of times they would prescribe that on top of SSRIs and other treatments. So that would really help with sleep in general, but it was mainly just maintaining a good sleep routine that would be really helpful. Stress management techniques, stuff like that would be really helpful for people. I found that was pretty effective, and they were still implementing that now. So that was introduced in 2010, and they're still using that. So it's really important. Yeah.
Did you notice like any big shifts in terms of like administration to administration, and how, and did any of that like translate into policy?
I found a couple, I found one source of a research paper saying that the 2023, the most recent guidelines, were not being implemented as effectively as were being stated in the guidelines. So I'm not entirely sure what it's like on a institutional basis. I'm sure it might be different depending on the funding, the hospital, the specific system you're in, or how much staff you have to incorporate. Like if you don't have enough staff that's trained in cognitive behavioral therapy, they probably won't be able to implement that effectively. So I guess it depends on where you are and what the system is like specifically. I am not entirely sure, because all the clinical practice guidelines that I looked through were written by researchers and doctors and administrators within the VA system. So as well as getting help from the Department of Defense. So I'm not entirely sure how it's being implemented actually, but I did look at a lot of effectiveness stats on SSRIs and how they're being implemented. So I found that SSRIs are only really effective around 6 to 12 weeks of using them. So there's also a lot of symptom remission as well that can happen. So it really just depends on the person and a case-by-case basis.
Okay. Interesting.
Yeah. Yeah.
So I came in late, and I apologize if you touched on this before I came in, and I think I may already know the answer, but has the VA been at all interested in looking at these more sort of cutting edge uses of things like ketamine and
Yeah, they have. I
Molly? And
probably go back to that in the slides. Yeah, so in the pharmacotherapy trends, they began mentioning this recently because they found that veterans were trying to self-medicate with cannabis and ketamine. And so they didn't really find that it was effective for treating really anything. So, I mean, maybe they could use it separately, but it's not really something that's recommended by the treatment guidelines at all. So, maybe that can be something that's further researched, but so far that's not really what they say about it. So, yeah. Great. That's it. Thank you.
Yeah.